The TNF, that is tumor necrosis factor, and interleukin 1 from activated macrophages act directly on the bone marrow and indirectly through activating endothelial cells, fibroblasts, and lymphocytes, and ultimately producing granulocyte monocyte colony stimulating factor, granulocyte colony stimulating factor, and monocyte colony stimulating factor, which acts on the bone marrow to stimulate production of granulocytes and monocytes come macrophages. Dear viewers, this video is part 4 of the 4-part series on the WBCs granulocytes in the Medicine for Anyone in the YouTube channel. Feedback control of macrophage and neutrophil responses. Although more than 24 factors have been implicated in control of the macrophage response to inflammation, 5 of these are believed to play dominant roles. See figure control of bone marrow production of granulocytes and monocyte macrophages in an inflamed tissue shown earlier. They are shown in the figure shown above and consist of the following: 1. Tumor necrosis factor TNF, 2. Interleukin 1 IL-1, granulocyte monocyte colony stimulating factor GM-CSF, 4. Granulocyte colony stimulating factor GCF-CSF, and monocyte colony stimulating factor MCSF. These factors are formed by activated macrophage cells in the inflamed tissues and in smaller quantities by other inflamed tissue cells. The cause of increased production of granulocytes and monocytes by the bone marrow is mainly the 3 colony stimulating factors. One of these, GM-CSF, stimulates both granulocyte and monocyte production. The other 2, GCSF and MCSF, stimulate granulocyte and monocyte production respectively. This combination of TNF-IL-1 and the colony stimulating factors provide a powerful feedback mechanism that begins with tissue inflammation and proceeds to formation of large numbers of defensive WBCs that help to remove the cause of the inflammation. Dear listeners, by the way, this educational video is made possible by Prescribe-On, the makers of e-prescription software of our digital prescriptions available freely for doctors on the website www.prescribeon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Formation of pus. When neutrophils and macrophages engulf large numbers of bacteria and necrotic tissue, essentially all the neutrophils and many, if not most, of the macrophages eventually die. After several days, a cavity is often excavated in the inflamed tissues. This cavity contains varying portions of necrotic tissue, dead neutrophils, dead macrophages, and tissue fluid. This mixture is commonly known as pus. After the infection has been suppressed, the dead cells and necrotic tissue in the pus gradually autolyze over a period of days. The end products are eventually absorbed into the surrounding tissues and lymph until most of the evidence of tissue damage is gone. This picture shows an eosinophil which has a bilobed nucleus and large bright orange granules. Eosinophils. See the figure of eosinophil shown earlier. The eosinophils normally constitute about 2% of all the blood leukocytes. Eosinophils are weak phagocytes and they exhibit chemotaxis. But in comparison with neutrophils, it is doubtful that eosinophils are significant in protecting against the usual types of infection. Eosinophils, however, are often produced in large numbers in people with parasitic infections, and they migrate into tissues diseased by parasites. Although most parasites are too large to be phagocytized by eosinophils or any other phagocytic cells, eosinophils attach themselves to the parasites by way of special surface molecules and release substances that kill many of the parasites. For example, one of the most widespread infections is schistosomiasis, a parasitic infection found in as many as one third of the population of some developing countries in Africa, Asia, and South America. An estimated 85 to 90% of the world's cases of schistosomiasis are in Africa. The schistosome parasitic worms can invade any part of the body. Eosinophils attach themselves to the juvenile forms of the parasite and kill many of them. They do so in several ways. One, by releasing hydrolytic enzymes from their granules, which are modified lysosomes. Probably also by releasing highly reactive forms of oxygen that are especially lethal to parasites. And by releasing from the granules a highly larvicidal polypeptide called major basic protein. In a few areas of the world, another parasitic disease that causes eosinophilia is trichinosis. This disease results from invasion of the body's muscles by the trichinella parasite porkworm after a person eats undercooked infested pork. Eosinophils also have a special propensity to collect in tissues in which allergic reactions occur, such as in the peribronchial tissues of the lungs in people with asthma and in the skin after an allergic skin reaction. This action is caused at least partly by the fact that many mast cells and basophils participate in allergic reactions. See below. The mast cells and basophils release an eosinophil chemotactic factor that causes eosinophils to migrate toward the inflamed allergic tissue. The eosinophils are believed to detoxify some of the inflammation inducing substances released by the mast cells and basophils. They probably also phagocytose and destroy antigen antibody complexes, thus preventing excess spread of the local inflammatory process. This picture is a basophil with large purple-black granules that fill the cell and obscures the nucleus. See figure basophil shown earlier. The basophils in the circulating blood are similar to the large tissue mast cells located immediately outside many of the capillaries in the body. Both mast cells and basophils liberate heparin into the blood. Heparin is a substance that can prevent blood coagulation. The mast cells and basophils also release histamine as well as smaller quantities of bradykinin and serotonin. It is mainly the mast cells in inflamed tissues that release these substances during inflammation. The mast cells and basophils play an important role in some types of allergic reactions because this type of antibody that causes allergic reactions, that is immunoglobulin E, has a special propensity to become attached to mast cells and basophils. Then, when the specific antigen for the specific IgE antibody subsequently reacts with the antibody, the resulting attachment of antigen to antibody causes the mast cell or basophil to release increased quantities of histamine, bradykinin, serotonin, heparin, slow reacting substance of anaphylaxis, SRSA, a mixture of 3 leukotrienes, and several lysosomal enzymes. These substances cause local vascular and tissue reactions that mediate many if not most, of the allergic manifestations. Leukopenia, a clinical condition known as leukopenia, in which the bone marrow produces very few WBCs, occasionally occurs. This condition leaves the body unprotected against many bacteria and other agents that might invade the tissues. Normally, the human body lives in symbiosis with many bacteria because the mucous membranes of the body are constantly exposed to large numbers of bacteria. The mouth almost always contains various spirochetal, pneumococcal, and streptococcal bacteria, and these same bacteria are present to a lesser extent in the entire respiratory tract. The distal gastrointestinal tract is especially loaded with colon bacilli. Furthermore, one can always find bacteria on the surfaces of the eyes, urethra, and vagina. Any decrease in the number of WBCs immediately allows invasion of adjacent tissues by bacteria that are already present. Within 2 days after the bone marrow stops producing WBCs, ulcers may appear in the mouth and colon, or some form of severe respiratory infection might develop. Bacteria from the ulcers rapidly invade surrounding tissues and the blood. Without treatment, death often ensues in less than 1 week after acute total leukopenia begins. Irradiation of the body by X-rays or gamma rays, or exposure to drugs and chemicals that contain benzene or anthracene nuclei is likely to cause aplasia of the bone marrow. Some common drugs, such as chloramphenicol, an antibiotic, thiouracil, used to treat thyrotoxicosis, and even various barbiturate hypnotics, on rare occasions cause leukopenia, thus setting off the entire infectious sequence of this disorder. After moderate irradiation injury to the bone marrow, some stem cells, myeloblasts, and hemocytoblasts may remain undestroyed in the marrow and are capable of regenerating the bone marrow, provided sufficient time is available. A patient properly treated with transfusions plus antibiotics and other drugs to ward off infection usually develops enough new bone marrow within weeks to months for blood cell concentrations to return to normal. Leukemias. Uncontrolled production of WBCs can be caused by cancerous mutation of a myelogenous or lymphogenous cell. This process causes leukemia, which is usually characterized by greatly increased numbers of abnormal WBCs in the circulating blood. There are two general types of leukemia, lymphocytic and myelogenous. The lymphocytic leukemia are caused by cancerous production of lymphoid cells, usually beginning in a lymph node or other lymphocytic tissue and spreading to other areas of the body. The second type of leukemia, myelogenous leukemia, begins by cancerous production of young myelogenous cells in the bone marrow and then spreads throughout the body so that WBCs are produced in many extramedullary tissues, especially in the lymph nodes, spleen, and liver. In myelogenous leukemia, the cancerous process occasionally produces partially differentiated cells, resulting in what might be called neutrophilic leukemia, eosinophilic leukemia, basophilic leukemia, or monocytic leukemia. More frequently, however, the leukemia cells are bizarre and undifferentiated and not identical to any of the normal WBCs. Usually, the more undifferentiated the cell, the more acute is the leukemia, often leading to death within a few months if untreated. With some of the more differentiated cells, the process can be chronic, sometimes developing slowly over 10 to 20 years. Leukemic cells, especially the very undifferentiated cells, are usually non-functional for providing normal protection against infection. Effects of leukemia on the body. The first effect of leukemia is metastatic growth of leukemic cells in abnormal areas of the body. Leukemic cells from the bone marrow may reproduce so much that they invade the surrounding bone, causing pain and eventually a tendency for bones to fracture easily. Almost all leukemias eventually spread to the spleen, lymph nodes, liver, and other vascular regions, regardless of whether the leukemia originated in the bone marrow or lymph nodes. Common effects in leukemia are the development of infection, severe anemia, and a bleeding tendency caused by thrombocytopenia, that is, lack of platelets. These effects result mainly from displacement of the normal bone marrow and lymphoid cells by the non-functional leukemic cells. Finally, an important effect of leukemia on the body is excessive use of metabolic substrates by the growing cancerous cells. The leukemic tissues reproduce new cells so rapidly that tremendous demands are made on the body reserves for foodstuffs, specific amino acids, and vitamins. Consequently, the energy of the patient is greatly depleted, and excessive utilization of amino acids by leukemic cells causes especially rapid deterioration of the normal protein tissues of the body. Thus, while the leukemic tissues grow, other tissues become debilitated. After metabolic starvation has continued long enough, this factor alone is sufficient to cause death. So, dear viewers, this is the end of part 4 of the 4-part series on the WBCs, that is granulocytes, in the Medicine for Anyone in the YouTube channel. Thank you for watching the video.